Hello everyone. Today we'll be discussing about standard precautions and transmission based precautions. So we'll be discussing on the following contents, which are we'll be discussing about the introduction of standard precautions, the components of it, and transmission based precautions. So what are standard precautions? The standard precautions are the minimum infection prevention practices that applies to all the patient care regardless of suspected or confirmed infection status of the given patient. It should be applied in any setting where healthcare is delivered. So talking about the history of standard precautions, in 1983, CDC published Guideline for Isolation Precaution in the Hospitals that contained a section called Blood and Body Fluid Precautions. It recommended precautions when a patient was known or suspected with bloodborne pathogens. But because of the HIV transmission increasingly showing its fear among the healthcare facilities and also all over the world, in August 1987, CDC published a document that was named as Recommendations for Prevention of HIV Transmission in Healthcare Setting. And in this recommendation, there was a section called Blood and Body Fluid Precautions that was to be implemented in patient care of all of the patients, whether he or she was diagnosed or undiagnosed, and it applied to blood and body fluids as well as other blood and body fluids like synovial fluid, CSF, pleural fluid, and so on. And this extension of blood and body fluid precautions to all the patients regardless of their bloodborne infection status was known as universal precautions. Universal precautions, as I already told, apply to blood and other body fluids that contained visible blood, alright? And it also applied to semen and vaginal fluid, CSF, synovial fluid, peritoneal fluid, and amniotic fluid, which were till then the known body fluids or known agents that could transmit HIV infection. But universal precautions, they didn't apply to feces, nasal secretions, sputum, sweat, tears, urine, and vomitus unless they contained visible blood. In January 1, 1996, CDC published a guideline for isolation precaution in the hospitals because there were so many confusions regarding universal precautions, and the body substance isolation that was published not by CDC but by infection control personnel at the Harborview Medical Center in Seattle, Washington. Still, body surface isolation also had some confusions. For example, gloves for anticipated contact with any moist body substance was indicated in blood substance isolation, but hand washing after glove removal was not required unless the hands were visibly soiled, according to BSI, that is body substance isolation. And this body substance isolation was simultaneously documented or simultaneously published in 1987. So what CDC did was, in January 1, 1996, it published a guideline for isolation precautions in hospitals. And this precaution guideline or this document was synthesized by merging the major features of universal precautions and body substance isolation in a single set of precautions. And it was to be used for the care of all patients regardless of their presumed infection status. It was called standard precautions. Now, standard precautions, they apply to all the body fluids, blood, body fluids, and all the secretions and excretions except sweat. Now we'll talk about components of standard precautions. The components of standard precautions are hand hygiene, use of personal protective equipment, respiratory hygiene or cough etiquette, safe injection practices, environmental cleaning, sterilization and disinfection of the patient care equipment, safe waste disposal also. So we'll now talk detailed about each components. So hand hygiene, it is considered as a major component of standard precautions. And strict adherence to hand hygiene in healthcare facility whenever there is an opportunity or whenever there is a moment that requires hand hygiene, then its strict adherence is always recommended. So what are the movements of hand hygiene? WHO has described these movements or these opportunities of hand hygiene, entitling My 5 movements of hand hygiene, and these are before touching a patient, before an aseptic procedure or risky procedure, and after a procedure or body fluid exposure risk, after touching a patient, and even after touching a patient's surrounding. So what are the indications of hand wash? And what are the indications of hand rub? As we know, in some cases, healthcare workers are washing their hands with soap and water, while in frequent cases, they are also using hand rubs. So what are the indications of hand wash and what are the indications of hand rub? We will be discussing. Whenever there is visible dirt or hands are soiled visibly, we should go for hand wash. Whenever there is contamination of blood or body fluids in the hand, whenever there is potential exposure to store-forming pathogens like Clostridium difficile, and whenever healthcare workers are handling patients having diarrhea, and after using restroom, before handling medication or food, we should use hand wash. And here is one interesting information that 4% chlorohexidine hand wash is preferred over hand rub or a plain soap hand wash while handling patient having diarrhea, and that is because spore forming bacteria like Clostridium difficile that causes diarrhea are not efficiently cleared out or efficiently killed or efficiently washed out when plain soap or alcohol-based hand sanitizer is used. And now we'll talk about indications of hand rub. The indications of hand rub are during routine clinical rounds and handling the patients. If the hands are not visibly dirty and if they are not contaminated with blood or body fluids, we go for hand rub. So how to hand wash? You can see here, first of all, you have to wet your hands with water. Apply enough soap to cover all the hand surfaces. Rub the hands palm to palm so that lather is produced out of soap. And firstly, right palm is held over left dorsum with interlaced fingers and vice versa is shown in the picture number 3 here. And then palm to palm with fingers interlaced. Then we go for backs of the finger to opposing palms with finger interlocked like this. And the rotational rubbing of the left thumb clasped in right palm and vice versa. We do it with both hands whenever I'm saying vice versa, right? And rotational rubbing backwards and forward and clasped finger of right hand and left palm and vice versa again to clean up the fingertips, as shown in figure number 7. Then we rinse the hand with water and dry the hands thoroughly with a single-use towel or paper towel by tapping. We should not rub vigorously while drying our hands with towel or paper towel, because that might cause abrasions and it might increase the chance of colonization by the transient flora, right? And use the towel to turn off the faucet of the tap. Now your hands are safe. So the second component of standard precautions, it is personal protective equipment. So what are personal protective equipment or PPE? PPE are wearable equipment designed to protect healthcare workers from exposure to or contact with infectious agents. This should be available also for family members or visitors. Selection of PPE is based on the nature of the patient interaction and anticipated exposure to an infectious agent. This means that you don't need to wear all the sets of PPE while handling every patient. You can decide as a healthcare worker whether you need all of the PPE equipment or some of them according to the nature of the patient interaction and anticipated exposure to infectious agents, right? So PPE selection is based on understanding the risk first. Understanding the risk includes risk recognition at first place and then risk assessment. What risk recognition means is a healthcare worker should be smart enough, or healthcare workers should understand the type of risk a patient might carry. For example, if a patient is coughing and sneezing, healthcare workers should be able to understand that droplet or airborne transmission might be there might be a chance of droplet or transmission based infection with that patient, and according PPE should be used while handling such patient. And what risk assessment means is to apply the knowledge of risk recognition and the knowledge of necessary PPE in action, right? The action taken by the healthcare worker after he or she recognizes the type of risk is known as risk assessment. So types of PPE. First of all, we'll talk about gloves. Gloves are a disposable barrier serving two primary functions: protect hands from potentially infectious materials, and they serve as a layer that can be removed along with any microorganisms, so that preventing the transmission after a procedure has been completed. The gloves include examination gloves, sterile gloves, and heavier reusable gloves. The examination gloves are used for procedures. The examination gloves are used for procedures where there is a risk of transmission of infections from patient to the healthcare workers. Potential exposure to the blood or body fluid, excretion or secretions, contact with non-intact skin or mucous membrane. These are the examples of time when examination gloves are used. These examination gloves, they are non-sterile but clean, of course. And the second type of gloves are sterile gloves. Sterile gloves come with specific characteristics of thickness, elasticity, and strength. They are used for sterile procedures like surgery or catheter insertion, etc. And they are packaged in individual sterile sets, right? Now, another type of gloves are heavier reusable gloves. The heavier reusable gloves are indicated for non-patient care activities, such as handling and cleaning of contaminated equipment or surfaces, right? And one more thing about gloves and the relation of gloves and hand hygiene is that use of gloves never replaces the need for hand hygiene. hand hygiene before and after gloves use is strongly recommended. And next items for PPE are masks and respirators. Here we should, as healthcare workers or students of healthcare, we should be able to differentiate between masks and respirators. So masks, they prevent splashes or sprays of body fluids, respiratory secretions and chemicals from reaching the mucous membrane, that are mouth and nose. They also block respiratory secretions from healthcare workers' mouth to patient during surgery or lumbar puncture, etc. While respirators are the type of equipment that filter particles or microorganisms from the air, greatly reducing their number which wearer inhales. Right? Example: N95, KN95, FFP2, etc. What N95, what N in N95 denotes is they are non-well resistant. That means N95 respirator or N95 mask, we commonly call it mask, but actually N95 is a respirator. N95 respirator is not recommended to be used in the laboratory or in the healthcare facility or in the room or in any type of work where oil-based or oil-containing aerosols are present, right? They are non-oil resistant. And KN in KN95 denotes Korean N95. Other things are same. And FFP2 denotes filtering face piece, and it defines various classes of filtering face pieces or filtering half masks, which are the entirely or substantially constructed of filtering materials. Well, one more thing, there are two categories of respirators. One is air purifying respirator, forces contaminated air through the filtering element, and the most hospitals use respirators, which are air purifying respirators. N95 respirator is a very excellent example of air purifying respirators. And another is air supplied respirators. This provides alternate supply of fresh air to the healthcare worker who has been wearing it, right? Another slide. Gowns. Gowns are a physical barrier that protects clothing and skin from infectious material when contamination by splashes or sprays are possible or likely. And then comes aprons and eye protection shields, and additional PPE contains head coverings and rubber boots. There's another component of standard precautions, respiratory hygiene or cough etiquette. SARS outbreak in 2003, it highlighted the need of prompt implementation of infection control measures at the first point of encounter within the healthcare setting. Right? It applies to any person with signs of illnesses, including cough, congestion, rhinorrhea, or increased production of respiratory secretions. The elements of respiratory hygiene or cough etiquette includes education of healthcare facility staff, patients and visitors about the importance of respiratory hygiene and cough etiquette, posted signs in languages appropriate to the population served with instruction of how to implement respiratory hygiene and cough etiquette within the healthcare facility or even outside the healthcare facilities. Source control measures, for example, use of tissue or surgical mask while coughing or sneezing blocks the infective microorganisms within the source, right? And hand hygiene is very important. Then spatial separation of the patients, ideally 3 feet, right? because droplet infections they can be controlled in a very large amount or large results whenever there is 3 feet or 1 meter of distance maintained between patient and the healthy individual. Now comes sharp safety. Sharps injuries are primarily associated with occupational transmission of hepatitis B virus, which is often denoted as HBV, HCV, hepatitis C virus, and HIV, human immunodeficiency virus. But they may be implicated in the transmission of more than 20 other pathogens. After a percutaneous exposure, the risk of acquiring HIV is 0.3%, hepatitis C virus is 1.8%, which in many studies it has been shown to be 0% to 7%, and hepatitis B virus to be the highest, that is transmitted approximately 6% to 30% after a percutaneous exposure or after a sharp injury, right? So to avoid sharp injuries, the unnecessary use of sharps and needles should be avoided first. Never recap the needles. Use single hand scooping technique if recapping is unavoidable. Do not try to break or bend the needles. Do not leave sharps and needles on the bedside or trolleys anywhere. Place the sharps in puncture resistant containers like shown in the figure. Or electric syringe destroyer or needle destroyer or burner can be used. The syringe or needle burner or destroyer looks like this in the picture. Safe injection practices. Use of aseptic techniques to avoid contamination of sterile injection equipment. Aseptic techniques is the must whenever you are trying to penetrate through patient's skin, right? And avoidance of medications from a syringe to multiple patients. Appropriate disposal of injection equipment after use, and use of single dose vials for parenteral medications whenever possible. Avoidance of administration of medications from single dose vials or ampoules to multiple patients or combined leftover contents for later use helps to reduce the injection-based transmission of infections, right? If multi-dose vials must be used, both the needle and cannula and the syringe used to access the multi-dose vial must be sterile every time. Bags or bottles of intravenous solutions should not be used as a common source of supply for multiple patients. Infection control practices for special lumbar puncture procedures during myelograms, lumbar puncture, and spinal or epidural anesthesia. Here's a very interesting story about how CDC included special lumbar puncture procedures, right? Infection control practices for special lumbar puncture procedures. It was a element that was added later in 2007 document by CDC. And the story behind why CDC implemented or documented this new element in standard precautions is that CDC investigated 8 cases of post-myelography meningitis in 2004. Blood and or CSF of these 8 cases yielded streptococcal species consistent with oropharyngeal flora, and there were changes in the CSF indices and clinical status indicative of bacterial meningitis. Equipments and products used during these procedures, example contrast media, they were excluded as probable sources of contamination because they are usually sterile. And procedural details were available for 7 cases out of 8. And antiseptic skin preparation and sterile gloves had been used. However, none of the clinicians or a face mask. And this provides a speculation that droplet transmission of oropharyngeal flora was the most likely explanation for these infections. So use a face mask for the individual, placing a catheter or injecting material into the spinal or epidural surface is indicated by ICPSC. As ICPSC is a Hospital Infection Control Practices Advisory Committee that provides advices and guidelines to Secretary of Department of Health and Human Services, the Assistant Secretary of DHHS, the Director of CDC, and the Director of National Centers for Infectious Disease. Now comes another very important component of the standard precautions, which is environmental cleaning or environmental measures. It is very important to clean or disinfect or sterilize the frequently touched surfaces. The frequency of intensity of cleaning may need to change based on the patient's level of hygiene and the degree of environmental contamination. Frequently touched surfaces, especially those closest to the patients, should be considered into priority of cleaning, and these include bed rails, bedside tables, commodes, doorknobs, sinks, etc. Certain pathogens like rotavirus, norovirus, and Clostridium difficile, they may be resistant to some routinely used hospital disinfectants. Since Clostridium difficile may display increased level of spore production when exposed to non-chlorine based cleaning agents, and the spore are more resistant than vegetative cells to commonly used surface disinfectants, some investigators have recommended the use of a 1:10 dilution of 5.25% sodium hypochlorite, or say 0.5% of sodium hypochlorite solution, which is often also called household bleach, and to be used routinely for environmental disinfections of the rooms of patient with Clostridium difficile. Next is spill management. It should be attended immediately with the use of proper PPE. Marking of the spill area and uses of signage is very necessary. Containment of spillage with an absorbent towel is the first action that we take. And for large spills that are more than 10 centimeters, 0.5% of sodium hypochlorite is used, and for small spills that are less than 10 centimeter of approximate diameter, 0.05% of sodium hypochlorite is used. The contact time is 10 minutes. That is, sodium hypochlorite should be let to react with the contaminants in the spillage for at least 10 minutes. This type of signage should be used whenever there is a spillage, and every healthcare facility should have a spill management kit available at any moment of time. So next is sterilization and disinfection of patient care equipments. Medical equipment or patient care items may be reusable or of single use. Whenever the medical equipment or patient care items are reusable, disinfection or sterilization of these equipments before using on another patient, according to the manufacturer's instruction, is very much recommended. Single-use device or patient care items do not need reprocessing, but they should be disposed considering them as infectious waste. The Spaulding classification informs our approach to disinfection and sterilization. The Spaulding category includes 3 classes of equipment that are non-critical, semi-critical, and critical equipment. The non-critical equipment are the objects that touches only the intact skin. The examples are blood pressure cuffs, stethoscopes, high-touch environmental surfaces, and they should be reprocessed or they should be disinfected by low-level disinfections. And the examples of low-level disinfectants are quaternary ammonium compounds, fluorohexidine, etc. And next is semi-critical equipment. The semi-critical equipment are the objects or equipment that touch mucous membrane or non-intact skin. For example, endoscopes, laryngoscopes, respiratory therapy equipment, vaginal specula, etc. And this should be sterilized with or disinfected with high-level disinfectants. The examples of high-level disinfectants are aldehydes, which might be glutaraldehyde, formaldehyde, or orthophthaldehyde, and hydrogen peroxide, paracetic acid, etc. And next comes critical equipments. These are the objects or equipment which enter normally sterile tissue or vascular system. The examples are implants, surgical instruments, etc. And they could be sterilized by using autoclave or hot air oven or maybe glutaraldehyde, right? Now, safe waste disposal is another very important component of standard precautions. Out of total waste generated in the healthcare facilities, 80% is general, non-hazardous waste, and remaining 15% only is hazardous according to WHO. And 15% is considered hazardous and they might be infectious. They should be handled as if they are highly infectious. The 6 key steps to implement healthcare waste management system are waste minimization, waste segregation at the source, waste collection and storage, waste transportation, waste treatment and disposal, monitoring and evaluation. Here is the example of color coding of bins for waste segregation in a healthcare facility. Green bin is used for non-hazardous biodegradable wastes. Blue bin is used for non-hazardous non-biodegradable wastes. Red bin is used for pathological waste, sharp waste, infectious waste, pharmaceutical waste and cytotoxic wastes. Yellow bin is used for chemical waste and black bin it is used for radioactive wastes. However, the sharp wastes are recommended to be segregated in the puncture-proof separate bin with a signage of infectious agents, right? Now we come to transmission-based precautions. Transmission-based precautions are considered as the second tier of infection control measures, sometimes also called isolation precautions. They are used in addition to standard precautions for patients known or suspected to have microorganisms needing extra precautions to prevent transmission. They are used based on clinical observations when certain pathogens are suspected and continued until the pathogen is ruled out. The laboratory tests, especially culture results, they take time. So, healthcare workers should not wait for the laboratory results to start transmission-based precautions. So, what are the types of transmission-based precautions? The types of transmission-based precautions are based on the mode of transmission of the suspected or non-pathogen. And the 3 main modes are contact, droplet, and airborne. So we'll talk about contact transmission first. It is the most common mode of transmission of infections in healthcare facilities. From one infected or colonized person to another by direct contact transmission that involves both a direct body surface to body surface contact and physical transfer of microorganisms between an infected or colonized person and a suitable host. Indirect contact transmission. It involves a contaminated intermediate like fomites or contaminated hands. Agents that are transmitted through contact transmission includes methicillin-resistant Staphylococcus aureus, carbapenem-resistant Enterobacteriaceae, vancomycin-resistant Enterococci, multi-drug-resistant non-fermenting gram-negative bacilli like Pseudomonas, Acinetobacter, etc. Agents of conjunctivitis like adenovirus, gonococcus, chlamydia, etc. Group A streptococci or staphylococcal or herpes simplex virus lesions. Skin infestations like scabies. Agents of diarrhea like cholera, rotavirus, clostridioids difficile, etc. And enterically transmitted hepatitis viruses. Control measures are hand hygiene. As we have already discussed, hand hygiene are considered the most important element of standard precautions. So strict adherence is always suggested, and 4% chlorhexidine hand wash is preferred while handling diarrhea patients, as we discussed earlier. And use of PPE like gloves and gowns before entering and before entering and they should be removed before leaving the patient area. Surgical masks and eye wears and hand hygiene before donning and after doffing the PPE. Containment of the PPE after use is also very important because transmission of infectious agents could happen through PPE if they are not disposed or they are not contained properly after use. Patient placement is very important. Single room isolation, rooms with bathroom and anteroom are preferred, and patient notes and bedside they should be outside the room, and donning and doffing of the PPE it should be done outside the room, and doors should be closed, and use of a sign on the door indicating that this room is infectious helps in understanding by other healthcare workers or patient parties to be cautious. And cohorting is important when single room is not available for each and every patient. Patients with similar infections or similar type of clinical features, they can be placed in a single room with spatial separation of 3 feet and a privacy curtain in between the patients, and visual cue like colored curtains, colored tape or mat, bed spreads or indicator boards or labeled patient case file used to indicate restricted access or special precautions if needed, right? And transfer of patients. While transferring the patients, the infected area should be covered and the transfer of patients should be limited only to medical necessary purposes, and contaminated PPE should be removed prior to transport, and clean PPE should be worn if the patient needs any assistance once reached the destination. Patient equipment and environmental cleaning is also important, like disposable or patient dedicated patient care equipment should be used. Disinfection of the equipment is very much important before use on another patient. Rooms of the patient cleaned at least once a day with a focus on frequently touched surfaces and equipment. They should be cleaned prior to be used by another patient, and use of PPE while cleaning and proper discarding after use. Now comes droplet transmission. Droplet transmission applies when patients have known or suspected infection transmitted by respiratory droplets. The respiratory droplets are of size greater than 5 micrometers, which makes them different from the respiratory droplet nuclei, which are lesser than 5 micrometer in diameter, and they transmit through airborne transmission. We'll discuss that later. Let's stick to droplet transmission now. Droplets are expelled into air when patient or people cough, talk, or sneeze. They can also spread by hands when people sneeze or cough into their hands and then touch mucous membrane of another person. Special air handling and ventilations are not needed to prevent droplet transmissions because these droplets, which are of size more than 5 micrometers, they can travel only up to 1 or 2 meters, and spatial distance between patients or between patient and healthcare workers, while not necessary, it reduces the chance of transmission of droplet infections. Here is a picture showing that the droplets, they spread in lesser extent than airborne spread of droplet nuclei, which are of lesser size. The agents that transmit through droplets are diphtheroids, Bordetella pertussis, which causes whooping cough, Haemophilus influenza type B virus, Neisseria meningitidis, Group A streptococci, rhinovirus, rubella virus, mumps, adenovirus, etc. The control measures. Hand hygiene is very important in this case too, because some agents, they are transmissible by droplet, are often transmitted by hands, and strict adherence to 5 movements of hands help to drastically reduce the potentiality or the chance of transmission of droplet infections. Use of mask is very important. Masks should be put on before entering the patient area. Protective eyewear or goggles in case of potential splashes or sprays in the mucosa, and some instructions should be given to patients, like use of tissues while sneezing or coughing. If there is no availability of tissues, then elbows should be used, and never cough or sneeze on the hands. Clean the hands as soon as possible after sneezing or coughing or getting in contact with droplet particles. And in outpatient setting, segregation of the patients with respiratory symptoms helps somehow in reducing the chances of transmission to another patients, and fast-track attendance to these cases which show respiratory symptoms also helps in reducing the chances of transmission. Here is a picture showing germs, they spread easily, so always carry tissues and use them to catch your cough or sneeze, and don't let your cough or sneeze spread out. And as soon as the cough or sneeze is catched, the germs, they can live for several hours in the tissues, so proper disposal of these tissues as soon as possible is necessary. And finally, kill the germs. Your hands, they can transfer the germs to every surfaces you touch, including the other people. So clean your hands as soon as you can. Patient placement is very important in controlling droplet transmission of infections. So single patient rooms are preferred. In case of limited single rooms, prioritize the patients with excessive cough and sputum production. If single rooms are not available, placing a patient on droplet precaution in an area with immunocompromised patients should be always avoided. Patients, they should be physically separated at least 3 feet apart from each other using privacy curtains. And while transporting the patient outside of the room in medical necessary conditions, the patients should be instructed to wear a mask and follow respiratory hygiene and cough etiquette. And if the patient cannot tolerate a mask, healthcare person should put on a mask and the patient is provided with the tissues. Now we come to airborne transmission. The patients are placed on airborne precaution when they have known or suspected infections transmitted over long distance through the air. As I have already mentioned, droplet nuclei that transmit through airborne transmission, they have a very minimum size that is less than 5 micrometer diameter, and they can pass along with the gases or atmosphere or the air in the room or outside for a very long distance and long period of time. So special precautions should be taken in case of suspected or known airborne transmitted infections. The organisms that acquire airborne precautions include Mycobacterium tuberculosis, the measles virus, and the varicella zoster virus that causes chickenpox. The control measures include: ideally, patients should be placed in an airborne infection isolation room. The airborne infection isolation room design includes a negative pressure. That is, the air should pass from corridor towards the room, not from the room to the corridor, right? And 6 to 12 air exchanges per hour is the required negative pressure of an ideal airborne infection isolation room. The exhaust of the air to the outside should always be away from the places where people walk and congregate and any air intake openings. The doors should be kept closed when not necessary for entry and exit, and the room should be strictly prohibited to general public or unauthorized healthcare workers too. If airborne infection isolation room is not available, use a room that has good cross ventilation, 2 or more windows that are open to the outdoors. Use an exhaust fan in one window to assist moving room air to outdoors, making sure that exhaust wind is away from people and any air intake openings. Turn off air conditioning and open windows to enhance ventilation if an independent air supply is not available. Keep the door to the hallway closed, except for when healthcare personnel enters or exits the room. The proper use of PPE, including a respirator, and special care while transporting the patient are must. So with this, you can relate or you can take these references if you want to study in a deeper level, and I would love to take suggestions from you, and please stick with me, stick with this channel for more presentations and more conversations like this.